The physician support's always difficult because we pretty much, if we want something to be very successful, we kind of have to take as much work out of their hands as possible. So that's always a barrier with everything we do, because we find when they're engaged and they do talk to the patients about the programs, the patients are full on board. So that's always a little bit of a challenge. And then communicating value is been a challenge for me, because when I see that a program is working well and I want to expand it or move it to other areas, it's communicating the value that we've seen in our programs to the leaders, especially if it's leaders that are not clinical leaders, and they're in other areas of the organization. So for me, that I think we've done pretty well with this program. I applied for a core award and we won it for the organization, and that was my way of communicating value to try and, get recognition for what we're doing. But that's always a challenge to me. And then the business model, we just had a meeting yesterday with our other teams. We're part of a bigger continuum of care. We work very closely with 5 other departments. We all report up to the same VP. And trying to leverage this program across all the continuum is always a challenge, because every department has their own way of doing things, their own personalities, and trying to all get on board, that's a big challenge for us too.
So for you, the 3 that are sort of rising as persistent challenges are physician engagement, communicating value, and business model, which makes sense. And maybe, and you guys were well along your process of care management coming into IOCP, but you could see that for groups when you're first starting IOCP, it might be a different set of 3 items. I mean, you're starting to enroll patients or that. Other thoughts on sort of the big areas?
So I think that our issues are not so much around the actual program, but it is around demonstrating value in what we're doing. And it's on a very different level, because we have evidence like the results from the PAM and the assessment scores that show that it makes a difference. We have some decrease in ED days and hospital days, but when it comes right down to it, the 2 owners are looking for a financial payback. So more shared savings. We don't know yet what this year is going to bring for us, but and the doctors are saying, what's in it for us? We haven't seen a shared savings yet. So even though in our hearts we know that care coordination is making a difference, I mean, we've got great stories about how it really is impacting individual people, as well as some of the other financial landmarks like decreased ED visits and so on and so forth. But when the owners have to continue to put money into the organization, that's success for them, is not having to do that, not the other pieces. And so it's how do you demonstrate that?
So yours is communicating and demonstrating value within the context of what they perceive as value or recognize as value, which is a financial return. And then how do you move, what I heard within that was, how do you move from being a cost center to something other than a cost center, this notion that we're just feeding money to you to do your work. Interesting. That will rise as one of your higher ones. I think we're seeing really a little bit of a theme. Yes?
With us, a lot of challenges that we had was the effectiveness of our leadership. I mean, we have great, innovative leaders on our team, but when it comes to so many visions, because everyone has this opportunity, it becomes a challenge when it's decided on, okay, which vision are we to follow? And how are we going to implement that vision? And how are we going to continue to communicate? So that could also fall in the lines of staffing, I don't know. But who would carry out those values, getting the right individuals to carry out those values. And again, along with implementation and following up, constantly overlooking at processes. How can we make things better? What's working, what's not working? And allowing the team to freely be open with saying, you know what, this really is not working, especially when it comes to those who are the frontline staff. you have the visionaries and you have those who actually have to carry out those visions, and it's always you're going to get two different outcomes. So it's about being open to accept that feedback from that front line, say, I know this is how you saw it, however, once we implement it, it's all wrong, basically. So that was one of our challenges.
Yes, good humility in that. So I heard a couple of things that maybe aren't exactly on this list, which I really like. So one is sort of the overall leadership commitment and support, and how do you continue to engage that. The other, which I heard, was sort of this openness, this willingness to be wrong, this openness to have a table where people feel comfortable saying things, which is a little bit of culture, actually. And I think that's actually a reasonable one that probably ought to be on this list, which is challenges around culture, kind of in an Uber way. Because as I heard you talk, at first I was thinking, what you're demonstrating, which I think you did also, is that there's overlap in these, that you can't do sort of staffing without physician engagement. There's some overlap in that. But a broader theme around culture actually makes a lot of sense. That's probably additive to this list that wasn't there in our earlier discussions, which often emerges that when you try to implement something, you realize that maybe one of the barriers is actually culture. And I'm not saying that in your case, but it's important for us to recognize that one of our challenges might actually end up being what the existing culture is in an organization.
And the strength that you have or don't have to kind of buck the I don't need that thing.
Lori's going to be mad at me.
We are required.
I'm sorry. I need this thing. I think being able to have the strength to kind of buck those challenges, buck the culture, it's one of the things that you meet up against all the time is, but this is how we've always done it. And then having somebody buy into and want to be part of that culture that's to me is one of the most difficult challenges.
Yeah, so it's sort of resilience within the culture and needing to be able to tolerate what the cultural constraints are, but then having the strength and sort of the boldness to push back at the right points at the right time. And we know that can go well if it's done in a calculated way. We know it can go poorly as well if there's sort of pushback that's not received well, that's sort of not within that. And when you have culture that isn't open, you often run into that tension of where can I push back when my resilience is sort of strong and I'm ready to do it. Yeah.
And we're really struggling with an integrated system for our ambulatory care management. I mean, our care managers will have to look at the hospital records to check admissions. They have to enter all the data, the enrollment. I mean, there's so much output, but there's nothing. And then when we have audits, and then we have to gather so just having that integrated system where we can, have the EMR, the hospital systems, all the data, all integrated. That would be so tremendous. That's just something that we continue to have a challenge with.
So that's interesting. It's data challenges, but it's more specific than that. It's data challenges because theoretically you're all one organization, but your systems are different. So there's differences in how you work. And how you collect data, and then can you bring that all together? I think that's a really interesting one. What I'm hearing is sort of within these, and these are exactly how you guys reported them, and we collected them, I guess, at the time. What's neat, even just 6 months later, is the nuance with which you're coming back and saying, no, it's real specific, and that's great. We're sort of understanding what the big challenge is within it. Tori?
So I think it's interesting when we talk about culture and paradigm shifts and integrated systems, and recognizing right now we're in a really difficult place because one person's gain is another person's loss. So as we try to build an integrated system, the things we're trying to do, say on the foundation side, that can also be running counter what potentially could be on the acute care sides. And so I think as we're trying to build skill sets is what we're trying to, essentially helping primary care to not just tackle a schedule every day, right? But to think about managing a population is really a giant culture shift. Mm-hmm. And what do you have to put in from an infrastructure standpoint and processes to be able to support making that happen? And it feels like now that we're really at this like field of dreams place, meaning that we know that we need to build these things out, but the returns on them can't quite actually be seen to be utilized right now because of the way the payment systems are set up. So that's a really strong force that we're trying to overcome. And as you're trying to craft all these things, you know, business models and scaling, we're up against a lot of that, because what is good for one may not be good for the other, and then how do you rectify those as you're trying to move forward? And that's one of, I think, our biggest challenges right now.
Yeah, that's a great point, and one that's not necessarily up here, I think, in terms of stakeholder perspective and how different stakeholder perspectives may lead to tension points that we recognize when we look at it from their perspective. Because many of us in the room would say, absolutely, sort of building complex care management is of course the right thing to do. I mean, our patients need it, and when we as healthcare individuals in America wake up every day, our only most important goal ought to be taking good care of people. And then you have sort of the tension point where the same stakeholders will say, or different stakeholders will say, yeah, we agree with that goal, as Tori said, except we also, in order to take care of people, need to be financially viable. And the current method for financial viability, which leads to taking care of people, is actually at odds with your method of taking care of people, which is build programs that cost money. And how do you marry those two together? And I think that a really good point, one that I wish we could say we would answer in this room across today and tomorrow, but one that probably, I think, as we're getting further in all of our sophistication, rises as worthy on this list of stakeholder perspective, tension. Vilma, thanks.
I think one of the things that we've done to make it easier for moving forward, planning for sustainability and getting the buy-in of senior management is in the course of doing this program, we incorporated it into the full ambulatory care management suite. And so it was subject to all the measurements that we were already doing on all the other programs. So we've run ED, readmission rates. The only thing we didn't do is the patient satisfaction survey, because that would have been duplication in the view of the patient, which could have been a dissatisfier. However, in the two measures that we've done consistently, it was really a big change. For example, when we were at we were still involved in Pioneer population, once we got off Pioneer, it gave us the ability to do measurements, and at that time we were at 47% decrease in ER and a 35% decrease for readmission rates on patients that we have managed through IOCP. And then most recently, we've done another cut of the data, and we're up to 54% and 57% decreases. And this is our patients' one-on-one measure, meaning to say 6 months prior to entering IOCP, we have a baseline data, and 6 months following the completion of IOCP case management on these members. So I think along with that, we also did a routine productivity measurement methodology on the course of the project. And we've gained some efficiencies to the point that I now believe in really doing team care in terms of case management, because I know that you establish rapport with the patient by having the one-on-one relationship with the case managers. But as we moved into the model, I've learned that having good communication between teams and having huddles really improve that communication and connectivity with the patient, so they know who's calling them, they know who's seeing them at home, they know who they'll be meeting at the doctor's visit if it's necessary. And we've learned a lot, so those are just a few things that I think had helped me move this model into sustainability and a good possibility of integrating into the rest of the case management suite of programs.
Yeah, it's interesting. So as I hear that, a couple, again, new themes that could probably fit within some of these emerge. One is integrating into other programs. which is really important. And then I think rightfully productivity at our team level. So how are we most efficient as a team? So again, more things that emerge as we go deeper in these conversations as really important challenges that we face, and things around which starting solutions are emerging on that. Other thoughts on this top 3 that you'd identify for your organization at this point?
You know, we're like sisters and we're competitors at the same time.
That is like sisters, right?
Yes.
That's redundant.
So I appreciate your data, sounds great, Vilma. We did not see a difference in ED at all. We did see a difference in everything else, but on our ED visits, we did not see a difference. I'm thinking maybe it's access issues, because we do have an access issue within Sharpey-Steely. So that's what I'm hoping it is, because I was very impressed by your numbers. So taking that one step further, you know, I love to spout numbers like that, because the data team sits under me, and we finagle, you know, not finagle, but we go over all the data, and we really try to look at everything that we can. But when I bring it to senior leadership, it's like, well, that's not because of you, that's because of all the things that we're doing within the organization. And, you know, but I think it is because of us, because I see a difference since we started the IOCP program. But that's another thing that's challenging for us, because I've learned that when you want to show the value, you also have to pump up other programs and include them in your overall, we're all doing a great job, yet you want to separate out what you're doing because you really want to continue what you're doing. So,
well, that was a very good point of view, because actually majority of the programs in ambulatory really shows a positive change prior to intervention and after. But it's just that for IOCP, the way we kind of integrated this model into how we're doing care management, it was just through the roof, and I was very, very surprised with what I found. At first, when I did the Pioneer, I said, this is senior population. I expected that. But when I had a better cut at all the data and a mixture of all the different payers, that's when it showed up to me, and I thought, there's validity to this now that we have been in this for over 2 years. So.
Yeah, and it's an interesting, again, a new tension point of, I want to integrate in with other programs, but I also want to be able to differentiate the value I'm bringing, and how do you do that? The entrepreneurial world, when you look at sort of startups and emerging companies, what they'll do is they'll define what the outcome is, and so when they're actually making the sale, so you're making an internal sale, when they're making the sale, they'll say that the outcome that we're going to be measured by is X, Y, and Z. So if you buy our product, expect that to be the outcome we deliver. What most of us have had to do, for better or for worse, and there may be an opportunity to shift it, most of us have had to fit into outcomes that someone has already defined for us. So our leadership has said the outcome is, say, shared savings, as Jan said, or the outcome is ED visits, or reduced admissions, right? So we didn't have a chance to define whether that's the outcome that we think we'll be able to show in 6 months or 12 months. We were just told that's the outcome you need to show, and so we sort of hustled to create models that might do that. If you truly were sort of a startup, an entrepreneur, starting a new company, a new product, you'd say, here's the product I'm doing, and the outcome I think that I'm going to have is this intermediate milestone. So for example, we hear right now startups say the milestone is engagement. And they convince the buyer, the purchaser of their product, that if we're getting engagement, we are then, if you step forward, going to show you the results you need. But gosh, in a year, we're never going to show you the cost results. So buy us if you think that if I can get you 70% engagement, that's going to be of value to you. Think about that, and actually come with me at 1 o'clock thinking about that around innovation accounting. Let's join and say, what are the things that if you were to set up metrics for your program, not constrained by what someone else already thinks are the metrics, what are the things you guys would say are metrics that you can prove out in the work that you're doing? That's sort of that innovation accounting component of it. If you were a startup, if you were saying, here's my program today, here's the stuff I do, my team does, what do I think in 12 months I'd actually be able to prove? maybe those should be our targets. And then maybe someone will push you to say, prove it sooner, prove something else faster. But what's our starting point around that? Because I think that's a really interesting tension point that you guys share there. Are going to next talk about what we call capturing our work. And you could call it measuring value as well. So there's a couple of ways we've talked about it. Why we call it both things is because I think that when we think of capturing work, we're thinking about it coming in, and actually there's an activity to it. They're actually doing something to pull it in. Capturing feels much more mobile than measuring, but the capturing our work allows us to measure value. So that's why those titles kind of go together with some intention. Capture, mobile, active, measure value. So that's the speaking out, the communications piece. What I think we'll do is we'll walk through 6 or so slides where I'll share things that mostly you've probably heard, but with a bit of context to it, and get to a point of innovation accounting. And then we'll do a little bit of, again, group brainstorming around certain challenge areas and how do we measure progress in those challenge areas. We saw a little bit of that this morning. I thought one of the innovative accounting measures was what Polyclinic shared around revenue to the practice. So that they captured patients who had not been seen in some period of time at the practice, so to some degree disengaged, and then they said, we engaged them, and we now have this visit rate with those patients. So interesting, kind of using previously untapped data in a way that highlights value. So let's kind of have that kind of a thinking cap on. When we think of our work, so if we're going to capture our work, what is our work? I guess we tried to simplify and probably oversimplified, but kind of put a stake in the ground and say it's redesigned care for differentiated outcomes. So the goal is differentiated outcomes. The way you've approached it is some care process, some specific, intentional, deliberate care team, technology, process, all of that comes together to create differentiated outcomes. So the question then is, how are we capturing those differentiated outcomes? How do we know if we're delivering differentiated outcomes? And I hear a lot of that this morning as we were talking, which is, well, I'm just not sure how we tell people about the value story on this. How do we show them that we're making a difference? And what does it mean to make a difference? I think that's a big part of being able to tell people we are making a difference. Well, what does it mean to make a difference? How do we measure it? And then once we measure it, how do we use the information we get? So again, using Polyclinic's example, from what Phil described earlier, they're using that information as a value add back to the organization. I think explicitly, care management isn't booking that revenue. It doesn't come into care management, but it does play out in a storyline to the organization around value. So that's sort of the, how do we use the information we get? And can we come together, both from this room and then in our dispatch we'll include things that we're learning in other parts of the country as well, but can we come together on best practices in measurement strategy for accountability and for innovation? And can we use measurement as a basis for doing things better? So in some ways you could say the explicit reason to measure something is to know how you're doing. And the reason to know how you're doing is so you can do it better. And if you believe that we're constantly trying to get better, you have to measure to get better. And I don't think anyone in this room probably disagrees with that. You may have constituencies in your organization that make it really hard for you to measure. And collect the data, but I don't think we should, we have a lot of dissent on, we want to measure as a basis for doing things better. We're sort of scientists by nature in this room, and we know the way to know whether something's working is through data. I think our intuition is just historically flawed. If we don't measure, and this is, I think, the problem a lot of us are speaking to, actually, if we don't measure, its impact of what we're doing is unknown, the effectiveness is unclear, and value undetermined. And that actually means all the way back to how we communicate it. So if we don't know how we're doing, then we have a difficult time actually communicating that value. And that can play out in, we didn't measure it, and we don't know how we're doing, so we can't share. Or it could play out the way I think Janet described artfully, which is there's lots of things going on, and we don't know how to isolate our value, or we aren't able to sort of put guardrails around it. So it's hard to say we brought that value. We have intuition around that. We have maybe even more than intuition around that, but how do you sort of pull that out into value? So this is what happens if we don't measure. This unfortunately looks pretty familiar if we sort of historically look out, mostly outside of groups like you all. You're pretty progressive. groups that have been sort of committed to complex care management, and over the last year or so, we've really driven hard on the need to measure and the need to know effectiveness. When you go at large sort of nationally at medical groups, this is actually what you see. Groups doing things that they think make sense, a lot of times starting with kind of science that told them it was going to make sense, and then ultimately not measuring, and then not knowing whether there was effectiveness or not. And that's why a lot of programs struggle, in fact, because if you can't show value when it comes down to budgeting cycle, and somebody said, I think maybe Tori said, that we're always in budget cycle, right? So when it comes down to budget cycle, you're always sort of trying to figure out, how do we retain what we had? How do we expand what we have? So really important. So kind of point one out of this session is really the reinforcement of the need to measure in order to show value, or you'll never be able to show value. And we're going to focus our time in the next 30 minutes or so on the measure component of the build, measure, learn cycle. I think the build you guys have been doing, and if you do the measure right, I think you have the force of intellect to do the learning part of it, and then the refining of the build. So traditional measures, when we think about complex care management or care management, traditional measures sort of focus on the triple aim. That's sort of the usual way over the last decade or so we've really thought about measures. And we know there are familiar challenges around the triple aim, sort of on the cost side, the amount of data you need, the length of time it takes. On the quality side, sort of equally in terms of the data acquisition part of it, and is the data all held within your system or somewhere else? And on the patient experience side, multiple moving pieces. I mean, how do you know your initiatives are the ones driving patient experience? And then I think someone mentioned earlier today that, I mean, if you survey patients one more time, it's going to start leading to dissatisfaction. So you're starting to see this sort of overburden of the surveying that's happening. So lots of traditional challenges to the traditional approach on measurement. And we don't see a lot of instances of alternative measurement in this sort of a group, these kind of care management initiatives built inside of medical groups. Some of that is data capture, and some of that is sort of visibility. How are we looking at that data within it? And then once we get that far, bless you, once we get that far, we see even the most sophisticated groups have trouble with this one. How do you translate data to drive change? Because a lot of you actually have some good starting data. We've talked about that, and how do you turn that into a driver for change? And we do that even at the patient level, right? So we try to show patients their data, and we say to them, you know, it goes either way. We show them their A1C, and it's going up, and we said, okay, look, the data science shows that, the data we captured shows that the A1C is going up. The long historic data says that if your A1C stays at this level for a long period of time, it probably won't be very good for you. And we're hoping that drives change. So how do we actually translate that data to drive change? It may not just be showing people the data, because my example right there, we know a lot of patients don't actually respond to that information. A1C high, long-term consequences of A1C being high are bad. Can you change what you're doing? And we don't get the response we're looking for. Same thing in your organizations. Data, saving ER visits, saving readmissions, whatever it might be. Just showing it without sort of showing impact and value to it won't drive change. So that's going to be a really important part. How do you use the data to actually drive change? One that not many groups spend a lot of time thinking about, and I'll encourage you guys to think about that and share if you're doing it.
Can you give an example of
Give me like 2-3 minutes. We're going to get to that. That's what we're going to spend most of our time talking about, sort of this innovation measurement. The example I gave from polyclinics is one example of kind of alternative measures to thinking about value, but we'll go a little bit deeper on that as well. Yeah, thanks. Yeah, I can help you with that. We're trying to be disciplined on the mic component. So the traditional challenges, I talked about lag in outcomes and results, talked about measurement infrastructure. So the need to kind of pull in lots of data. Grenda shared how it's hard actually when you're even in an integrated system, getting the different pieces of data all together. And then once you go out even one layer, you have health plans and their data could come in. And so we have more data than just about any other industry, and yet we seem to struggle the most with data in terms of how we use it. The small sample volume is a challenge. It's hard to sort of convince the actuaries of things because our volumes don't sort of match up to kind of actuarial needs in terms of data. And even sometimes academic research requires much more data. And it goes back to, I think, that makes sense for potential for harm type innovation, probably makes less sense for harm-free innovation or do no harm innovation. So thinking about that, and then what we measure. So that's sort of the traditional metrics of what we measure. And I'll jump to that because it goes a little bit to Chuck's question around what kinds of things could we measure? What are alternative measures that get us towards that? And I think the biggest one is the intermediate variable. So what are the, if this occurs and then this occurs and then this occurs, it's likely to have a quality gain. If this occurs, this occurs, this occurs, we're likely to see savings in cost that we might not see in a period of time that's defined by some stakeholder, but we might be able to say it's starting to happen. We know that these, if A happens and then B happens and then C happens, it's moving to D. And those are things that I want us to brainstorm a little bit in a second. But so it's sort of this right-sized engineering, right-sized metrics. That one's key. What is the thing that you're doing and how do you measure that thing that you're doing, right? So if you're doing a program for high-risk members, and it has very little transitions of care built in because some other group in your organization does transitions of care, and then you see readmission rates go down, it is going to be hard to know whether you had an impact on that or they had an impact on that. You have to find, when you're doing innovation, metrics that are as cleanly related to what you guys are doing as possible, because that helps you to drive kind of the value story that you're going to have. Do micro-interventions, because micro-interventions are a bit cleaner, actually, when you're changing things small and rapidly. I like the EPIC example of the multiple steps, and I know there was 5 across 18 months, which probably each of those had multiple steps within it as well, so you guys are probably constantly kind of micro-intervening. And then this notion of build, measure, learn through it all. And then what do we measure? How do you decide what to measure? And we'll come back to that in a second as well. So innovation accounting is what I want to spend most of our time on, because I think most of us know that if you wanted to do sort of a long-term cost-saving study, you would probably do more traditional academic research, propensity-matched control groups. You'd have as many multiple variables as you can. Ideally, you'd have exactly the same enrollment criteria, which we know is a big challenge in these sorts of models. You'd have a long-term study. You'd have sort of a 3-year study or a 5-year study. Some might argue longer than that. You'd have fixed interventions, like you couldn't change anything if you're going to do sort of traditional academic research. Once you pick the intervention, even though you realize that maybe you needed a social worker in there, you're actually polluting the study if you add that into the model. So you have to sort of stay in a fixed, rigid environment. What you guys are doing is sort of an entrepreneurial environment. That's sort of the pace that you're moving at, and that's sort of the agility that you need to move at to be able to be successful. And so Chuck asked about alternative measures. We'll also sometimes call them non-traditional measures. And we will sort of inspire you to think about hidden or unused measures and data sources. So an example I think I've probably shared with this group was we looked at ER visits for a large academic hospital system in the southeast of the US. They were struggling with an increase in ER visits. And we were trying to figure out why they were seeing this acute ER visit increase. And it actually came down to looking at time of day that the ER visits were happening in. This was an unused metric in their system because claims don't show time of day cleanly. So we actually had to go into the ER system and pull the administrative data of when somebody checked in, actually, because it wasn't even kind of when the note was signed. It was when somebody had checked into the ER, which led us all the way back to the and it wasn't so easy. I mean, it was a somewhat long process to come back to their highest time of day for where their rate of increase was occurring in the ER. So not the highest use of the ER, which was traditionally in the evenings and nights, but their highest rate of increase was actually between 3 and 6 p.m. And then we went and looked at their capacity in primary care, and it's actually when they had the highest capacity. They had the most open visit slots between 3 and 5 p.m. And so we had to do some digging, and it's actually how you then take non-traditional, unused data, time of day on the ER visits, and then convert that or translate that to Explore. And what we found out was there was a different initiative happening in primary care on the outpatient side to reduce overtime. And so when people were calling the clinics, the clinic triage was encouraged that if it appeared to be something that was going to be a pretty lengthy ordeal, or if it appeared to be something that ultimately was going to need to go to the hospital anyway, encourage the patient to seek other care and actually maybe even help them facilitate other care. So once that whole cycle was observed, it was like, oh, well, of course, no doubt, right? But it took us like a couple months and lots of data stretching. And the aha moment came in unused data, the untapped data of timestamps when a patient entered the ER, sort of when was the check-in moment for that patient. Not when the physician saw the patient, because a lot of these patients were actually lower risk, so they were triaged and it took them longer to actually get in to see the physician. But that was the timestamp of when they entered the ER. So push yourselves towards what data do we have, what unused data do we have, how can we report it? What are intermediate outcomes? Sometimes at RenHealth we'll talk about that as kind of unpacking, so going from the outcome that we're looking for and what are the different pieces of that outcome we might see along the way that become sort of intermediate outcomes. New value points. How do you define what success is? So if it used to be only cost, are there other value points within that we should look at? And maybe we'll look at kind of value in terms of cost, and maybe we'll look at a slightly different one in a moment. You guys talked a lot about physician engagement in a previous session. We'll maybe look at those two as innovative accounting and get your thoughts on that. And then that part about turning data into something usable, data science driving change. And a lot of that means defining, measuring, and then communicating. And we'll often say upwards, inwards, and outwards. So inwards to the team that you're working with, upwards to leadership, outwards to your other care partners, whether that's the primary care providers, the specialists, the other folks in the stakeholder community that you need to work with. And the communication probably is pretty different to each of those, and it's probably pretty different for the very reason that we talked about with, I think with Tori earlier today, was that the lens of the different stakeholders has a different sense on value. So your primary care doctor, as Erin shared with us, their primary care doctor just wants to take care of the patient in that moment. And the CFO is saying, well, I want to take care of thousands of patients across lots of moments. And how do we reconcile that? Well, the value to the PCP might be, look, our care management is effective in taking care of patients with you that you're managing on a day-to-day basis, and here's the quality metrics. And oh, we can associate those quality metrics to a reward, an incentive that you're going to get back, as an example. But the CFO might say, well, I'm not so interested in that part of it. I actually want to see overall that the economics of the whole organization are translated to success based on care management. So when you think about communicating value, and that's not the piece we're going to spend time on today, but think about that in terms of what am I going to say to which stakeholder that matters? Who sort of matters in me moving forward, and what's the storyline of value for them? And then how do you sort of validate that process, that building, that measuring, and then to learn and creating that cycle? That's sort of a piece, I think, that once you get those measures right and you can turn those learnings, you can keep that cycle going. It's a little bit of what turns that wheel on an ongoing basis. So once you've sort of seen that sort of larger picture, then it's how do you capture that? What do you actually do? So acceleration is one of the pieces that we need to, in healthcare, do a little bit more of. Our traditional models sort of have a lot of patience, I would say. We say, okay, this is going to be a 3-year study, or even in this initiative, right? So IOCP, 2+ years of intervention, and then CMS will get a whole bunch of data, and they'll have to wait for claims runouts, and then they'll have all that data kind of cleaned, and then that data is going to go to, I think, Mathematica, who's their vendor, and then Mathematica will do some formatting and organizing and cleaning of that data, and then they'll spend as much time as they need to have the academic rigor to actually report out. And so you'll know sort of from day one, the patients you impacted, you'll probably know like 3 or 4 years later what the impact of that is, right? And we're okay with that in healthcare. That's sort of what we've been doing. So we sort of say, oh yeah, that's how long it takes to know if something works. And yet you're on this constant budget cycle. You're always needing to prove yourself. And so you don't have four years. So even after we come up with what measure you're going to show, what we'll encourage you to do is say, how could you do it faster? How could that even be done faster? How could you measure the outcome of that faster? Because that increases your pace of learning. That increases your ability to kind of have stakeholder feedback and communication. So if you're going to do a test, and it's, I think those of us in the morning we talked about, Dr. Zachary shared a test that he sent this email out to the docs asking for their support, and then went one-on-one to each of the docs, really asking for their support. And I don't know how they did it, but as I hear a story like that, I think to myself, you could probably learn a lot if you did like 20 of them in like 3 days. If you figured out how to really accelerate your process. Because your organic way might be to say, yeah, I kind of need to do, there's 200 docs and we'll just space them out over 6 months or something like that. You'd get a lot of learning across 6 months, but imagine if you said, well, what if I did 20 in 3 days? I'd actually get a lot more learning that will refine how I do the other 180. And that's sort of accelerating that pace of the learning loop, accelerating the pace of the feedback that you're going to do, and then translating that to value. So once you've learned something, how do you translate that to value? So we did the interviews with the docs. We spoke to 20 of them. We got 5 of them to agree to do referrals. My new measure is on those 5 that agreed to do referrals, within 30 days, how many referrals did I get? If there's an uptick in that referrals, then I probably have spoken to some value to the docs. And then I got to think, well, now how am I going to show them value on those referrals? Because just the referral itself isn't the end point. Now I say, wow, good, I got them on board. Now I need to make sure I'm showing them that the feedback loop goes all the way back to the work that we're doing with the patient. So it's this constant process, and that's why I think it was a really interesting question that I think Jonas asked to Epic's team. Do you ever sort of have process fatigue? Do you ever sort of have fatigue around that innovation? Because it sounds like a lot of work if you're constantly doing it. But if you create a culture of being a learning organization, it doesn't feel like a lot of work. If that becomes your deliberate framework, it actually feels like an inspiring kind of learning process. And your team becomes a learning organization that says, this is how we do our work. In a way, it's what lean says. I mean, a lot of you talked about doing lean. In a lot of ways, that's what it is. It's sort of these rapid process improvement workshops kind of on an ongoing basis. It's transparency, it's visibility, and this is the same sort of learning process that we're talking about in a little bit of a different way. So how do we get to kind of innovation accounting, the innovative measures? What are those measures going to be? Well, here's some attributes of the measures, that they're accurate, they're effective, they're available, and they have pace, that we can actually get a bunch of them quickly. So I wouldn't encourage you, if you're trying something new and the amount of episodes of that something new is going to need 12 months to get enough volume to learn anything. That's not a fast-paced environment. We say that with shared decision-making with your care coordinators. That if you're, trying shared decision-making for the first time as an organization, pick some sort of decision that you have a lot of volume on, so that in 30 days you know. If you pick kind of a rare condition that has 2 different potential diagnostic or treatment pathways, but you only get 1 a month, it's going to take you a long time to know whether that shared decision-making process is effective or not. If you pick something that has 10 a day, then you're actually going to capture a bunch of information. So thinking again about sort of availability and speed. Some people use SMART metrics. I know some of the organizations here use them: specific, measurable, attainable, realistic, timely. And then we'll add to that, once you get that measure, is it actionable? And then can it drive change? Kind of this constant reminder that the reason to measure is for a basis to get better and better, and that's sort of the main reason to measure. So how do you go from insights to actions? I think that the way we look at it is that data kind of has this opportunity for discontinuous leaps. That you're sort of on trajectories, and if you have the right information and you capture it in the right way and you translate that into information that's usable to refine your processes and then communicate it out to the right stakeholders, you can create discontinuous leaps. So the example, and I used this term earlier when Dr. Brown shared that they borrowed from best practices elsewhere to, instead of starting over in their organization, they sort of started at that point. So they had evidence of something that worked, process evidence. I don't think what Dr. Zachary described was an academic study. He didn't say, I worked with 3,000 physicians over 2 years, and we proved that by me sending an email and then going and visiting them that we had more engagement. He said, nah, this is what we did. This is what we did these 4 things that didn't work, and I remember him sharing a bunch of things that didn't work, and he said, we landed on this, and ooh, this started working, so we just kept doing more of it and getting better at it. And then that allowed St. Luke's to say, okay, well, let's start there. That's evidence, that's good data. It gives us a discontinuous leap. So what you're looking for in data is not just to support the trajectory you're on, which is helpful, but looking for opportunities to make discontinuous leaps as well, to kind of jump way forward based on the data that you're seeing. So let's pause, and I know that was a bit rapid cycle. For those who are new to the room, that might have seemed like fairly new material. I went fairly quickly because those of us who have been in the room in November and in some of the intermediate sessions have heard a lot of this philosophy and principle behind measuring. And so I wanted to sort of get to an in-room sort of discussion. Be interested in maybe taking one or two topics. The two that rose from, I think, this morning were just how do we speak to our value, and how do we do physician engagement in stronger ways? And I think the physician engagement one might be a little bit easier to start with. In trying to hear from you, how do you determine whether you have physician engagement? What's sort of your metrics that you're using? And how specific can they be, and what's sort of your timeline? So maybe I'll just track here a little bit. What the metric is, and maybe there's three topics: what the intervention was for physician engagement, what the measure was, the metric that you use to decide if you're getting better physician engagement based on that, and then what the timeline is for that measure. Let's start with that and kind of do a little bit of group exercise. And the value of this is not to solve physician engagement. The value, hopefully, is to hear each other and us together talk about how we get to kind of innovative accounting methods. How do we get to kind of innovative metrics? So thoughts on interventions, metrics, timeline. And it'll look neater in the dispatch. It won't be sort of written in my scrawl. We'll try to type the dispatch, so we'll capture in a more readable format. But what have you guys tried to do on physician engagement, and then how did you measure whether it worked or not? Brenda, please.
It's more of qualitative measure.
Sure.
So we do a physician huddle for those sites that have an embedded IOCP nurse and health team in there. And so we will huddle with the physicians and get more of feedback from them as far as what's working, what's not working, and how. So it's a qualitative measure.
Okay, so you do huddles with the PCPs, and how do you decide if you're getting increased engagement or not?
Well, usually we will start with a few physicians at a particular site.
Okay.
And
small batch engineering.
Yeah, the early adapters. So we will select who we think are early adapters. And then once we have the early adapters, I mean, it's really that endorsement from those early adapters to the others. So it's a trickle effect. And so when we have additional physicians at that site who are asking us, when am I going to be able to, so that's how we know.
So
that they're
inbound
engaged.
inquiry from physicians is something you're looking for.
And they will inevitably inquire with the nurse care manager or the health advocate at the site and ask, when am I going to be able to enroll patients in your program?
Okay,
So-
and you said it was qualitative, so I'm not trying to
Yes.
put you on the spot, but do you guys actually measure it and say, we touch these 3 early
Yes.
adopters and we now have these 6 asking?
So in any given, every month I have to report out at each medical group how many physicians that are enrolled into our program. And so we do have a metric.
So number, and enrolled in the program means, how do you decide if they referred somebody or they actually verbally?
They have
Number of,
referrals. They're actively referring to the program.
okay. Okay, so that's cool. So you said that we're going to actually measure physician engagement, and we think our intervention is that we need to expose the early adopters to the work that we're doing. That's our intervention, and we're going to small batch it. We're just going to do it with the early adopters. And then we expect, our hypothesis is that there's a trickle-down effect to the other physicians, and we're going to measure that trickle-down effect by number of PCPs referring patients. Did I get it right? Okay, that's great.
So how we started is that we used our champion physician, which is Dr. Shaw, to outreach to providers who he already had an existing relationship.
Okay.
So we used him to outreach to those providers to start with. to get their okay to can we start off managing a patient and to get the okay for future references. So that way we don't have to keep asking them once we find patients later down the line. To measure that is that from the referrals, not just from referrals, but with them asking, calling, and sending us emails. Question, I have a patient. Do you think this is a candidate for someone you can manage? So it was that type of engagement that we also kept track on top of the referrals. Just them calling or emailing me asking, can I get more information about this program? Is this patient suitable for your program? And then we followed up with sending flyers to the providers just so they can remember that we're still here in the event that we have not got any referrals from them.
Okay, so it was the medical director doing one-on-ones with them. Is that Dr. Shah did one-on-ones, and then you measured if the one-on-ones were effective by number of referrals and number of inquiries that were coming in. And then your feedback loop was for people with 0 referrals, you gave them more information, the flyers. Is that right? Correct. Okay, that's nice. And so these, both of these are really good examples of we took an intervention and we found ways to measure it. And then you have a new innovative measure, which is actually how many kind of emails with questions or phone calls with questions we're getting, which sort of drives towards these folks are engaged. And then I like the feedback loop. If you're not engaged, well, we're going to try something else, an additional thing to you. Other examples of what you've tried with physicians? Or other measures you've used around physician engagement? Yeah, thanks.
So we did, following the lean principles and practices, 30-day, 60-day, 90-day check-ins with the physicians. We initially started it with like 4 pilot tiers, physicians like the initial early adopters, and then have them give sort of testimonials in front of their colleagues, and then show their data. And then during the 30, 60-day, 90-day check-ins, we showed the number of referrals, actually, like projected in the PowerPoint. And then health coaches would actually try to put themselves within the space of the clinicians who, may not have been doing a lot of referrals to them. And then on the research side, we did a baseline survey of physicians. We go to their department meetings at the baseline and did a survey, to assess their comfort with the new workflow and how they feel about managing patients with these multiple chronic conditions. And then we repeated it in 6 months and then in 12 months. So
baseline
kind of,
6 and 12 for that one.
Yeah.
And the initial intervention was early adopters who already were using care management?
That's right, yeah.
And they did what? I'm sorry, I missed.
So they would share their experiences
Okay.
at the department meetings. About
Okay,
how
so
it
the
goes
intervention
for
was
them.
early adopters already using care management share experiences.
That's right.
And then we measure whether that changes the referral volume from their colleagues.
That's right, yeah.
And we did that at 30, 60, and 90 days. And if they had low referral rates, you added a health coach in proximity.
Yeah, because the health coaches initially were, in their own office, with their nurse practitioner, supervisor, so they're not very visible. So these, so they get sent to meetings, and then they will get co-located, in the frontline offices. So that seemed to have, bumped referrals somewhat.
Yep.
It's still not perfect, but it's these are incremental changes.
Yeah, and so what would you do next? Do you guys have a next? Because you're right, none of these are perfect because we have lots of docs that we still need to engage.
That's right, yeah. It's hard to say the next right now because there's a lot of organizational changes and the leadership changes. There's a new service line. So we're kind of in a holding pad right now. I hope we will move forward. The research team actually, we have some interesting findings, early findings already. For example, in terms of what we call panel grooming, meaning health coaches or the MAs will reach out to patients who haven't been seen. Over 30% of them had made a new visit, which is a lot of revenue in a way. But we need to learn to provide this information to the front line and to leadership. So this is encouraging. This is very inspiring kind of for me to see that we need to make the data more visible.
Yeah, and I'm starting our next sheet as well, so we're going to talk a little bit about just value in general and how do we define value. And so you just said one intervention is MAs, health coaches calling disengaged patients, is that right?
Oh, yeah, yeah.
Disengaged patients. And what you measure is number of visits, new visits scheduled?
That's right, yeah, resulted from those
Scheduled.
outreach. Yeah.
And how soon do you pull up and measure whether that was effective or not? So they reach out, and you're trying to get, what timeline do you measure in?
So we've done this at 6 months after the launch and then 12 months after the launch.
Could you do it sooner?
Could we do it sooner? So the complicating factor is that we're in the research institute and we don't deal with live Epic data. We don't want to, bring down the enterprise by us looking around at real data. So we have to wait for our information management group to update the data, de-identify it, put it on our side of the firewall so we can work the data. So there is a lag because of IRB reasons or because of the workflow. So
your
we're
6 months actually
constrained.
builds a lag into it. There's 2 months worth of lag in there.
That's
or
right,
whatever
yeah.
it is.
Yeah,
Okay.
yeah. So we kind of have to do the academic evaluation, like we would propensity score match it with a clinic that's not doing champion.
Right.
Yeah.
Yeah, and the reason I asked, and again, not to put you on the spot, but the reason I asked is because this feels like something that we could do sooner. Like if you had access to dynamic data, but it sounds like you don't. It sounds like there's a barrier. But if you had access to dynamic data, this is a really nice intervention question, right? Which is, we're going to use our MAs and health coaches to call disengaged patients, and we're going to measure how many of them schedule visits. So if I have 100 disengaged patients and I have my MAs calling them within 2 weeks, I would guess that if they're going to schedule an appointment, that's going to happen pretty soon thereafter. And so I could probably in 60 days have a pretty good measure on that. So while we may think 6 months, and not in your case, you have a data barrier, but we may think traditionally in healthcare that, well, it should just take 6 months. That sounds pretty fast to me, actually, 6 months in healthcare. But can you do it faster? Push yourself. Can I do it in 60 days instead of waiting 6 months on something like that? What are the things how much volume do you think we'll need to be able to have some insight on that measure? So this is a great example of something on that. Thanks for sharing.
Sure, sure.
Yes, Tiffany. And I'm open to either physician engagement or value. I just sort of switched since the topic went there with Ming.
I guess this would go along physician engagement. And when we just first started the program, what we did is on a weekly basis measure for each care coordinator how many patients they had enrolled or how many patients had been identified that they could enroll. And our measure really was by the number of patients that that care coordinator was enrolling, because it is embedded within that practice. And so what we did is pretty quickly you would see there were certain that you had an engaged physician and they ended up, have the care coordinator had lots of enrollment, and we were able to realize right away that there were certain that weren't as engaged, and the team utilized that to figure out, well, what are interventions for that patient? These are things that I've tried, or for that clinic, these are things that I've tried, like getting the schedule, highlighting the insurance plans, or being around the physician when they were there. So it was a little bit more dynamic, but our measurement was how many patients did we have enrolled, and we measured it on a weekly basis.
Yes, I like that. So the intervention was care coordinators in the office, and then the intervention within that was best practice sharing amongst the care coordinators based on what weekly data was showing. So you looked at the weekly data and you said, oh, you look like you're getting a lot of volume enrolled. Tell us what you're doing. Based on what you're doing, we'll adapt somewhere else, and then next week we'll see if that worked. Is that sort of how it sounds?
Yeah, I think that's exactly how it worked. And you realize that there's a toolkit of ideas so that you're not just using one idea because it depended on the practice as far as what was the better idea for that practice.
Mm-hmm. Yeah, I like that. So that you're building actually a set of tools, and the more data you have, the more you can say this tool in this practice works, or this tool with this sort of patient works, which comes actually back to how other industries use data. They're pretty nuanced. They sort of take the layers. I think what we've been talking about here is great, and we've been using sort of that deeper layer than most people use, and then you can even start bringing multiple data metrics together. So for patients with CHF who have been in the hospital recently, we did this tool and it showed effectiveness. And can we then say, for patients with CHF, we have a slightly different way of engaging folks, and actually reduces waste because we're not doing the other way that we were engaging people. Does that kind of make sense? The more nuance you can get, the more specific you can get. You may do that with physicians as well. You may find that with physicians, and we've done this with organizations, with physicians who have been more engaged in their EHR implementation versus less engaged in the EHR implementation, we decided the approach for them would be different. That was our hypothesis. So the docs who were engaged in one type of innovation were more likely to get engaged in a new type of innovation. And then docs that really struggled, and this was maybe the bigger part of the hypothesis, the docs that really struggled with the EHR implementation were going to struggle with this as well, that they sort of just didn't like to buy in on these things, and they were going to need more hand-holding. They were going to need more immediate return on their value and time that was going into it, and they were going to need to be dissuaded that the problems they thought happened in the EHR won't happen in this. Which meant actually that the stuff we did with the docs who were sort of low engaged on the EHR, if we would have done all that same stuff with the docs who were highly engaged, we would have just been wasting time. It would have been too much resource to those docs. It wasn't efficient. And so separating that out and then watching the data and seeing if that indeed was true. And in that case it was. I'm using an example that proved out that the lower engaged docs in other innovations were going to be longer to engage in this intervention as well. Does that make sense? Yeah, Tori.
So I was just going to say, coming on board amidst the middle of the start of our project, the one thing that I noticed to help with engaging, it depends how you define physician engagement. For the initial engagement, I think to just streamline our approach in terms of we started to implement the P4P measures, routine screenings, and immunizations in our nurse care visits. And we sent that just a one-page summary to the physicians because initially there was too much paperwork, so it was getting overlooked. And right away we noticed, I guess from a numeric perspective, an increase in the amount of patients enrolled from the same physicians as well as from their partners. So we have an IPA, so sometimes we have solo practitioners who increase their patient referrals, or from our group of 2 or 3 physicians, then we now started having the other physicians, sign up for, IOCP. From a qualitative point, in order to maintain or sustain the engagement, it gets a little harder because we did get back the signed reports, so that was a way for me to confirm that these doctors are actually looking at what we're doing. But the second component was we also sent out little cards on behalf of the patient, and it said, "Thank you, doctor, for enrolling me in Spark, and this is why." And one of them was a patient, for instance, that was having back pain, and she started using her friend's walker just because she didn't know what to do. So we contacted the office, spoke to the physician, and was able to get her own walker, and that helped with her back pain. So when she wrote that note, it made a big difference, and the physicians actually talk, and so it was nice to hear them when they meet me to say, oh, this really made a difference, and then the other doctors get excited, and even though I've presented it multiple times, I think 10% do tend to forget what it is, the program, and so then they ask me, and we engage more physicians. Okay, I'm being nice, but the short-term memory, as a primary care physician, I'll admit to that. So those were some of the things we did, and the other thing was, in terms of making it easier, is you can refer your own patients, but we have a tool where we can find a list of your high-risk patients. Can we reach out to them? And once they gained enough trust, they would sign that. if you take, we're adding more help and we're removing your hard work, so we didn't have to wait for a one-by-one referral, and they were engaged because they were seeing the results. So those are some of the things that we did.
Really interesting, and so it sounds like initially it was kind of visibility into P4P type metrics, which then you could measure whether that increased. And it sounds like it did increase PCP referral and partner referral. So you're actually distinguishing between the actual visibility transparency group and their partners. And then to sustain engagement, you use sort of the patient thank you cards. And what did you measure for that?
Well, with that, we sent the cards, and that's a more qualitative feedback. So we would hear back, one of the cards I delivered myself, but the other ones we mailed out. So sometimes when I run into the physicians at other events, to hear back the response that, oh, thank you for reaching out to this patient. I saw the card. Some of them would say, oh, I got the card, that's great. So a more qualitative measure, because sometimes we forget that our patients are part of this program. And another thing was actually Misty had suggested that we get a Spark bag. That Spark is the name for our IOCP program. And that bag we encouraged our patients to use to take to their doctor's office, put all your medications in it and our binder. And in the binder, we had sections also created to take back specialist reports and cards from the specialist office, because there it is. He's modeling it very well. Thank you. So that's yes. And then they say, oh, the doctor remembers that my patient's part of this program, and they get excited because their patients engage in the program. And they liked that also with bringing back the specialty cards, because I struggle with that all the time in my office. Is a patient went to some specialist, I don't know who it is, where he's at. And you can Google 1 million doctors with my last name alone. So it helped to have that card for them. And the doctors noticed that, and they liked it too. So those little things are little for us to do, but they're really big on making a provider's life easier. So those were just some of the things.
Yeah, and those are really great examples. I appreciate you sharing the several of those, because I think one of the differences that emerged in my head as I think about physician engagement versus value, and we'll turn to value for a few minutes in a second, is that in the physician engagement, you can do sort of A/B studies. You can say, in this set of practices, we're going to do this, and in this set of practices, we're not going to do it. And then we can see if there's an impact. There's a bit more of a controlled environment. So you could say, for this set of practices, we're going to send thank you cards and see what happens, and these ones we're not. Or we're going to give bags, and these ones we're not. Which, as you think about what your outcome is, you may want to think about which ones can you do kind of rapid cycle A/B tests on as well. Sort of, here's the intervention in this group, we're going to hold a control group study. As we get out to value, it gets, in the big V sense, it actually becomes a little harder to do that without running into it being a lot slower. But I like, and I really like, for things like physician engagement, how can you measure it quickly? What are things you can do? Some non-traditional metrics we've heard in other groups is trying to share back to physicians the value of the program and seeing if that actually changes for them their referral pattern. So we've seen groups measure the length of visits for patients that are in the complex care or in Spark, in your example that we can use, versus patients who are not in Spark or pre-post on Spark, and we see visit lengths actually shrink pretty considerably, pretty fast, and that's pretty important to providers. You can do phone calls from patients in Spark pre-post to the office versus post to the office. So are you decreasing trouble to the office teams? Again, untapped data we tend not to look at, but it might be valuable to somebody in driving home sort of the engagement you're looking at. So this is sort of the innovation accounting. Can I look at the number of phone calls this subset of patients had prior to engagement? Can I look at the number of phone calls they're making into the office staff post-engagement? Have I reduced sort of the trouble to the office staff, that constant noise that goes on in primary care? If you can show that in valid data, you can then take that quickly to your physician partners and say, oh, and in addition to this long-term 12-month quality outcome, it's already going to actually save your staff a bunch of trouble. It's already going to reduce your visit time. Things like that become sort of innovative accounting. Another group that we worked with actually went to their docs who had what they perceived as low engagement. So they used a metric many of you are using, which is number of referrals coming from the provider. They went to the providers with low referrals, and they did kind of a test on both. The high referring providers, and I don't remember the exact question, but effectively the question was, can you describe what care management does, and what would you like it to do? And the high referring physicians actually could describe what the care management program did and matched with what they wanted to do. The low referring physicians actually couldn't describe what the program was, what the care management department was doing. They said almost the same thing of what they'd like it to do as the high referring docs, but that's untapped data, what's going on in the physician's understanding and the physician's sort of knowledge base on the program. That actually tells you what the intervention ought to be for that group of physicians. We ought to do something to get them to understand what care management is, because it solves the need that they're describing. So that's an example, I think, on a more defined kind of physician engagement. Do we have physicians engaged in our work? Let's take 5 minutes and just talk a little bit about value and non-traditional metrics that you're using to share out value. I think, Phil, you shared the one from Polyclinic this morning, how you guys are measuring visit rates for people who were disengaged, who then engaged in care management. What are other things you guys are doing? Because I think there is a call to action a bit to redefine value a little bit as well, to get ourselves out of the need to have long-term value. I said entrepreneurs today, starting companies, new companies, don't always say we'll show you cost savings in 12 months when they're talking to the payer or the employer, because we know that's actually pretty hard to do because of the way the data is structured. What are other value points you guys are measuring in your organization? Yeah, Jen. I thought I had a mic. Oh, there it is. Thanks, Tim.
Well, because we're an ACO and CI, we not only are looking at those things that are directly patient-related, like how many referrals does a physician make, but we're looking for referrals to other practitioners within our network. And of course, the idea is that we want to keep the business in our network. And so that's one of the things that we've been measuring on an ongoing, ongoing way.
Referrals to specialists within network.
Right.
Versus out of network. Are you doing a ratio, or are you?
And it's all referrals. So it's PCP referrals out to specialists, and it's specialist referrals back to other specialists in the network and or PCPs when a patient needs a PCP.
Okay. And are you doing that as a pre-post, or as a percentage of referrals, or as a ratio?
As a percentage of, yes, as a percentage of referrals. So, for example, the committee's just decided to really start to act on this information now. And so there was one practice who had only 13% retention within our network. The rest was all going out to St. Elsewhere. Okay. And so the committee actually invited them to come in and have a discussion with the committee about it. And the interesting thing is, it was kind of implied, you have a choice here. If you'd rather not be in the organization and go to St. Elsewhere. And the physician said, no, we really want to be a part of the organization. We can't tell whether it's an ACN patient when they come in or not. So the problem now to solve is kind of the same one talked about earlier, where how do you define, how can that patient know, how can the practice know when an ACN patient walks in the door? It's not like we are the insurer. Mm-hmm. So this just came up last 2 weeks ago. So
what a neat way of sort of doing this build, measure, learn, right? So you came up with a measure, so you built a network. You came up with a measure to see if people are staying sort of in the network. For people with low network, you went and talked to them, and what you learned, because you measured it and you learned that they don't actually know if somebody's in ACN. And so now you'll do an intervention to see if you can inform people if a patient's in ACN, and then you'll see that's the new build, which is build ACN tag or something like that, or flag, and then see if that changes your referral percentage.
And I believe that they're very committed. Once they've identified the patient, they said, once we know, then we will make sure that they go to one of our facilities.
And that's a good example of something that you probably could pretty rapid cycle figure out. So if you put in some kind of ACN tag, it won't take 6 months to know whether they increase their referral rate, especially if they're down at 16%. You'll see pretty quickly if they jump high.
I think so.
A good example. Yeah. Other ways you guys are measuring value, non-traditional ways that you're measuring the value of the work you're doing. We're going to look for intermediate outcomes. What are your intermediate outcomes to cost? Say more about that one.
Looking at pharmacy costs.
Mm-hmm. So looking at them in hopes they go up or down? Or in specialty pharmacy, or is it specific to something?
I think, part of the metrics is the overall pharmacy costs for that patient that's being managed.
Okay.
Try to look at where they were prior to enrollment in the program, and then once they're in the program.
Mm-hmm.
Oh, up or, well, hopefully down.
Down.
Yeah,
Okay.
yeah.
Alan says why?
Why?
Because Alan and I have talked a lot about how we tend to see in care management pharmacy costs go up initially.
Oh, I don't have results completely on that yet, but that's one of the things we're trying to look at. We also, especially people that have a pharmacy intervention, right? So the use of the clinical pharmacist in that, and what kind of impact that actually has. So it's a good point that you're right, it could potentially go up, but we haven't actually seen that yet.
Okay. Yeah, and especially when a clinical pharmacist is involved, we sometimes see it go up, actually, because adherence goes up. It's like sending someone to a specialist. Your surgery rates will likely go up if you send them to a surgeon. Your pharmacy rates, in a good way, will likely go up if you send them to a pharmacist. Initially, we see that.
Oh,
Specialty pharmacy can look a little bit different, but that's a different topic. Yeah.
In terms of value, I guess, we do a pre-visit checklist. So a nurse would do a chart review, look for P4P or 5-star measures depending on the population, see what, immunizations or whatever preventative measures that have not yet been scheduled. They'll work on that. They'll get the labs. If there's an A1C that's necessary, they'll get the lab order to the patient. They want all of that done prior to seeing the primary care physician. And so it's a kind of proactive approach so that when they see the primary care physician, it's a very value-added visit for the patient. And so we develop this pre-visit checklist. And then the other piece is the triaging. So now that they can call the nurse at the site instead of the physician for symptom management, that's a value-added piece.
Do you measure that? That one's a good one. Both of those are good ones. But that one's especially a non-traditional one. Do you measure sort of the triaging that avoids physician work?
You know what? And that's what I was going to ask. I mean, I wonder if anyone has like a physician engagement survey related to the IOCP program developed, because that's something I could see asking. Have you seen a decrease in triage, in your care management patients? Do you see a decrease in calls from them? And then we could use the same, measurements of likely, somewhat likely, or whatever, ridiculous.
And I encourage you to think about that as untapped data, because calls are logged somewhere, hard to report on, but that's probably data that exists somewhere. Similar to, I think, what Polyclinic did around ER visits. So if you call and you say, I'm about to go to the ER, you get logged as somebody who came in instead of going to the ER. Be interesting to see if your organizations have, it's been a while since I've tripped while presenting. I almost went down. It'd be interesting to see if your organizations have data that says the call volumes have gone down, or the call volumes to the nurse have gone up, but to the physician response need, like the percentage of calls the physician had to respond to has gone down. That's compelling data.
It should be in the EMR, because the clinic medical assistants are supposed to log all calls that come through.
Right.
So I'm sure it's there.
So I would
Yeah.
say that is hidden or unused data sources, things that we don't tap into. Another example of that, in a very different example around unused data sources is we look at claims, and one of the things we look at claims for is consecutive visits to the same specialist without an intervening primary care visit. It actually sort of shows disengagement from primary care. So you could then actually translate that to what Polyclinic did and say, well, there's another example of a disengaged patient. If I can start getting them to come into primary care between specialist visits, heck, I might actually even be able to start reducing specialist visits that are just on this cycle, this quarterly cycle of specialist visits that happen. So we've actually learned to really focus in on that metric. Again, sort of unused data. That data is in claims data. So if you're getting claims data, that's there. Most of us don't look at it with that in mind. It's actually kind of hard to report on, but that's important types of information you could report on. Other examples? Yeah, Alan.
Well, and not that I have data on this, but we've been talking about it a lot. If we're doing a good job at our work, primary care physician and staff satisfaction should rise. And that's a thing, which theoretically would lead to lower turnover rates. And
Yeah, so I like a couple parts of that, right? So there's one that I think we just all agree is important, which is physician or staff satisfaction. But then translating that to value to somebody is actually that's lower turnover rates. And there's hard dollars people can put to what turnover rates cost. And that's a nice way of translating something that feels like a qualitative metric to a quantitative dollar amount for folks. Thanks, Tori.
So another thing we're looking at, and it can either be cost or quality, is the access metric. And part of that we're trying to look at, is the panel size of a primary care able to increase because of the support of the team? And we have issues that we don't have enough access in primary care, so that if the team can support the primary care physician, can they do more, actually see more people?
Mm-hmm. Yeah, a great way of sort of showing increased potential for number of patients you can manage and revenue.
Can I speak to that? Because I think it's a really great point. It's hard to ask that. You can, if you ask physicians, can we increase your panel size, you will probably not get an honest answer, because that's sort of a big, oh no, I need a smaller panel, not a bigger panel.
I'm way too busy.
Right, but we worked with a group from a really successful high-functioning organization called RenHealth, and they're in Green Bay, Wisconsin, and sort of what did team care do for them? And it was team care including a lot of the model that we currently practice with. So this would apply more to an intensivist model than a not. What they found is that they actually were able to take their panel size for primary care from 1,500 to 3,000 by having a strong team around them and have higher physician satisfaction.
Mm-hmm. Which is the key, that last part.
Yeah.
That we didn't just overwork you and see higher turnover, we actually increased your satisfaction as well.
Right.
Yeah, because it's not total number of visits that the doc does, it's total number of people that can be managed, right?
Yeah, especially in a system, in an organization where you have hospitals and ancillaries and specialists and things like that in terms of your revenue. Yeah.
So our doctors don't want a huge panel because that means they have more diabetics that they have to keep in control. They have to make sure all the women have their mammograms. So
That is a what, sorry?
I know, but it's difficult because if you don't have really good scores, it's
Well, the
it's
way to
very
have
hard.
good scores is teamwork. It's not to ask the physicians to do it.
I understand, but they don't want, I'm telling you, they don't want a bigger panel because then they feel like there's more people that they're
Well,
responsible for
right.
taking in control.
But what this model is let us take that off your hands in addition to managing these difficult patients. And
Which I think leads to, if I were hearing what Janet's saying, it leads to, we'll need proof points to convince the physicians that it will lead to equal outcomes for them for 3,000 patients versus 1,500 patients, that they'll actually have to believe that the intervention actually works. Otherwise, you're just going to have resistance. So if we don't have data to drive change. And this comes back to how do you use data to drive change? Well, you won't get that change driven outside of mandate, but they won't be happy with mandate unless you have data that convinces them of it. And I'm hearing you. I think that makes sense to me. And so you could already, in an organization like what Alan described, they're already doing it. So it's easy for them to sort of cycle that, and they had to go through the hard part of driving change. It'd be really interesting at some point, probably not in this conversation, but to hear how they drove change, how they got from 1,500 to 3,000. Comment, Phil?
So we're in the middle of a experiment as well. So with our primary care value stream and redesign of primary care, we're going to do risk-adjusted panel sizes. And all of a sudden, now care management's everybody's best friend because the physicians and the care teams want that extra resource and they want their panel size to reflect the illness burden that they have.
And I think what I hear there is maybe a thread of what's missing sometimes is alignment of incentives. And I think that you guys have tried to align incentives by saying, okay, you don't want huge panels, we'll take on really sick people, we'll help you with really sick people, and that will be reflected sort of in this risk-adjusted panel size. And then your outcomes, which you're probably measuring as well, will have to, for them to continue to believe it, the outcomes will have to be good for people who took on sick patients. So, yeah, interesting. What I hear a lot of, and I love it, is ideas around value that care management's providing. What I hear a little bit less of is how that, and some of it actually I'm hearing that helps revenue, which is really important because I think to get an organization's buy-in, there has to be sort of smart revenue coming in. So not, can we figure out how to get more specialist visits? Can we figure out how to get more hospitalizations? But within the context of reducing it, can we figure out how to get more patients? And that would help us. So that's really neat. What I think I'm not hearing much of, but not surprisingly, and I think an observation that we can carry forward as we continue our work, is unpacking total cost, right? So if one outcome we're all forced to measure against is total cost, which speaks to ROI in some degree, how are we unpacking that to intermediate outcomes? And we talk about readmissions and admissions and maybe ER visits. Maybe you could do something around specialist visits, but I think we should push ourselves, and I don't have an answer up here either, but we should push ourselves to smaller and smaller intermediate metrics, more and more hidden data, bringing multiple data sources together to start telling that story around the value back. Yeah.
So one of the factors that I found really helpful in IOCP was the change in the PHQ-9 and the PAM score and the VQ-12. And I think that speaks to a lot of physicians that are, science-minded, data-driven. Would it be accounting appropriate to look at quality of life scores? Because overall, this is supposed to be about the patient. And ultimately, if that's obviously part of our triple aim is patient care, is anybody using a quality of life score, baseline, follow-up, et cetera?
Unfortunately, we haven't been in the program long enough to have enough VR12 numbers, but VR12 can be converted to a quality of life measures. So, yeah, so you can use that. You don't have to collect additional data, so to speak.
Oh, okay, we'll go Chris and then Jan.
But I think what you're asking is, can you quantify that value outside of just a score improvement? What does that translate to? How do you use that value to for other purposes, so that to convince your groups of the value of the program based on, and that's for us as well at Sharpey-Seeley. I think that one of the benefits that we had from this program as well, this participation, was that we would never have been able to get to the patient-centered outcomes were it not for the guardrails and for implementing them as part of the assessment. And as we sustain going forward, we're committed to those patient-centered outcomes because we believe that there is value, and we're not sure how to use it either, but there is value in quantifying it as it's scored, but then translation is not there yet for us. What isn't, we've learned a lot about engagement.
Translation to value to other stakeholders?
Exactly, because we've learned, from an NCQA standpoint, and we all want to keep our requirements, we know that patient engagement is, having this bidirectional relationship for 45 days. When through this 2 years to 3 years of the program, we've learned that patient engagement is far more than that. And what does your organization do for patient engagement? And then how does that reflect in the measures? And how does that help you as an organization? Does a more activated patient increase the value of what you've done over time? I don't know those answers.
Well, and I don't know that we can definitively answer that question, but it does feel like you're onto something, right? So we know that there are activation measures, as an example, that have seemed to translate out to cost savings or lower utilization. And so you're asking, can we, in the work we're doing, identify activation? So that it says question 1 is, where's the data? Is it hidden data around activation? Is it intermediate outcomes that say, now a patient's activated? I'd argue, for example, that higher drug adherence is a more activated patient. Or I'd argue that a patient that's going, their ratio of primary care to specialist visits is increasing. They're seeing more primary care than specialists, probably more activated. They're closing more of their gaps, more activated. So you could combine a bunch of things and say, look, our patients are now more activated. Then the question, which I think is a good one that you're asking, how do I translate that to am I going to save somebody cost? So the question would be, can I translate that to lower ER visits, or can I translate that to readmission rates, or can I translate that to admits or specialist visits? The big things, the things that cost a lot of money. And you might be able to translate that to readmission rates, and that may be an early indicator. So this is sort of how you unpack. You say, I have a hypothesis that activation is good for my patients, and it's actually good from a financial sustainability perspective. But I don't know how to prove it. So I have this hypothesis. I can prove I can increase activation. How does that translate to cost? And then sort of step yourself through that process to figure out which metric will I actually be able to change through activation. You might be able to use as a proxy something Pam might be able to show and say, okay, if I were to do activation, however I measure it, and if I were to say it's going to end up reducing ER visit rates, what's the fastest way I can figure that out? Can I find a bunch of patients that I now will say look activated based on these other metrics, pharmacy utilization, primary care versus specialist ratio, and number of calls to the care manager. I'm going to use those as my metrics for activation. And I'm going to look at their ER rates versus the people who don't have that level of activation. So the opposite people, they have poor drug adherence, they have a high specialist to primary care rates, and I can't seem to get them on the phone. And can I show an ER visit difference? You're starting to see, these aren't sort of academic studies, but they are starting to become kind of this A/B test where you're saying, okay, so I'm doing this stuff, and if I can get to these outcomes, these activation indicators, it looks like ER visit rates are lower for those patients. So that's how you start thinking about kind of this untapped data and translating it into something that has financial utilization, a little like Alan did with dissatisfied providers and turnover rates. How do you translate that into a financial number if we're talking about cost as a value? And then how do you tell that story outward? And you'll have to keep working on it. That's an iterative process. Jen?
Well, my question tags onto that, because one of the things that happens in our group is that it's total attributed lives and the cost. And so that comes down a little bit, but how do you tie that to the value of care coordination? And
because it's everybody.
Because it's everybody. And then some would say, when I say, but we can show that ED visits are down and whatever, but they say, yes, but these people were really, really sick. That's what pushed them into care coordination. And so we expect to see some decrease.
They're talking about regression to the mean.
So, so I guess that some don't see that as really being value for the whole. Does that make sense?
I think so. So you're being measured across the whole, and you're able to show some difference in the small that you actually care manage. But they're saying, well, that's not what's reflecting the whole. Something else is doing the whole, and what you're doing isn't the totality of it. And I think that's not an easy one to solve, because people do talk about regression to the mean, and we've had conversations around how regression to the mean has some flaw in this application because you're picking people who have impending doom. And so if you pick a bunch of people who don't have impending doom, they will regress to the mean. If you have this mixed bag of people who have some regression but a bunch of impending doom, because you're self-selecting high risk people. But then it's actually unpacking that, and we could spend more time, maybe offline, talking in more detail about unpacking that into smaller metrics to decide if you can translate where you're changing ER visits to the larger whole and differentiate that from regression to the mean. Does that make sense? Then you say, okay, I acknowledge regression to the mean. Let's figure out who that applies to, and then am I seeing the same kinds of patients that regress?
Right. Or is it valuable to say, this patient X spent this many dollars the year before they came into care coordination, and now they've spent this many? Is that, and it's down, is that of value? I mean, is that something that you can push out into the future?
Because you have to be able to show the absence of the unknown. If they wouldn't have had care management, what would have happened? Yeah, Tiffany?
So, being a very evidence-based person, this trying to prove value is totally not evidence-based because of what you were saying before. There's so much. And so we've done a couple things. One is you look at readmission rates, you look at those hospitalizations, you do all of those things that everybody else does. But the other thing that speaks is we did exactly what you said, is we have a number of patients that are patient examples of here they were. We have a couple where we get the cost, and we took the patient that, previous to enrolling in care coordination, their costs were $350,000. After that, it's $60,000. And just a couple of those case examples do end up speaking loudly, even to the C-suite executives, because they look at that. What did you do? It's very real and tangible. We've also looked at doing things like we have a health and HIE, so we can take a look and say, how many ER visits, how many hospitalizations, what was the length of stay before, and we did a number of case examples of this patient previous, and then about a year previous, how many ER visits, how many hospitalizations, what was the length of stay, and then once they enrolled in care coordination, what did that look like? And it's a really strong graphic picture when you put that up. And in the short term, those types of things, when they go along with some of the other things that you're seeing, overall decreased spend, overall decreased readmission rate, overall decreased ER visits, it gives you a little more credence that, hey, maybe it is our program that's responsible for at least a portion of the improvements that the system's making.
So it's interesting, you're saying take multiple data points and package them together into a story, and you have like a dashboard that you guys use, which sounds pretty great. Do you still run into folks giving the pushback that sounds like Jan hears, which is, well, those people would have regressed to the mean anyway, or are you able to get out of that discussion? Because I'm with you, they probably wouldn't have regressed to the mean because you're self-selecting sicker people. But
I don't think I don't think that we have seen that, and it might be in the selection that we've chose, the people that we've selected. We're not. I think it's maybe a good case, with your cancer patients or those types of things that, that's an episodic thing that it's going to be expensive, and then probably after that will regress a little bit more. But some of the people with these chronic health conditions, and especially with concomitant anxiety, depression, and that type of thing, which is probably or social issues that are leading them to the ER and the admissions, we're choosing those cases as our example cases. So it's harder to argue that they were going to regress to the mean anyways.
yeah, it's an interesting thought, because so I asked you to maybe unpack the patients and the data, but you could also unpack regression to the mean. There's probably data out there that we can look at and say, well, who does regress to the mean? Is it people with depression, anxiety, social conditions? Maybe the answer is no, I don't actually know that, but that would be great, because then you could say, well, let's just look at those people then, because those ones wouldn't have regressed to the mean. So it's unpacking sort of your comparative data as well. Really effective. I like that. Thank you. Phil.
Just to follow up on some of your comments, so our enhanced care program, IOCP, that team also manages team care. So this is a program that looks at diabetics where one of their 3 clinical indicators are not at target or threshold, and they're depressed. So we administer a PHQ-9. So what we found in that population is that once their depression was actually treated and their medication was optimal, we saw increase in activation and medication adherence and willingness to really work with the enhanced care team. So I think as we think about all of these other related measures, we have to look at, maybe there is some underlying medical reason as well, like untreated depression. Because we saw a huge increase, really. Our A1Cs were back in control on those patients that, where their depression improved or was eliminated.
That makes me think of that's a great example of sort of linking together a few data points to tell a value story. It also reminds me that sometimes we don't tell the counterfactual very often to and I don't know if that's the right word, but to our stakeholders. We're so, we have such conviction to prove our value out that we don't say, hey, we're also looking at the people for whom we didn't make an impact and learning from that. Because I think there's a lot of value to show the organization leadership that we're doing feedback loops. So here's a bunch of people that we didn't actually make an impact on, and here's what we're going to do next, and we need resources for that. So thinking through a balanced story is an important part of communicating the value. So we aren't spending a lot of time on the communication part today, but that's really important to communicate sort of, we've looked at all of this. We're not sort of looking just at one part of it. Brenda?
Just when we're onboarding new physicians, we give them a VERISC report with all of their patients, and it shows the risk scores. And it shows the likelihood of readmission or ED visit in the next 6 months. So we'll show them the top 50. I'm wondering if we could keep them out of that hospital in that 6-month period, and their VERISC score was, maybe the likelihood was 5 times as much as the next person. Can that be quantified as savings? I'm curious.
So, sort of. It can be quantified as predicted spend differences, so a change in predicted spend. You'd have to unpack that a bit, though. But I think it's an indicator towards it, that then you'd have to step through how a decrease in predicted spend, because VERISC score is based on predicted next 12-month spend. So you'd have to then unpack how your intervention showed that difference, and then how that difference is an actual cost savings. But I think there's something to it. I think those are kind of innovative metrics, sort of like innovative accounting. So let's, we're here. Let's just review real quick the key points, and then we'll talk forward. So intention in your measurement strategy, and I'm hearing a lot of it. It's actually outstanding to hear some of this, and I applaud you guys for the effort, both in the room, even talking about it today, and then the work that you're doing. Isolating. So we've heard a lot about the difficulty in isolating. Jan just told a great example that we hear in a lot of organizations, which is, how do I know the work I did was the work that actually drove the overall change? So the more we can isolate and accelerate. How entrepreneurs in other startups will do it is they'll actually pick their metric first, and then sort of, they have their model, but they get to define the metric. What we're stuck with is metrics others have defined. Historically, what we're working in healthcare with. But can we isolate the interventions we're doing, the micro-interventions? You actually did a really good job on that when we talked about physician engagement. You guys had sort of isolated interventions you're doing, metrics that you'd use, and feedback loops, which was really neat to see. Much harder to do, I think, on the value part of it when we're trying to define value. A lot harder, actually. This one's really important. No data untapped. If you have data, use it. Figure out what story you're going to be able to tell with that data. And I don't mean story in a fiction sort of way, but there is data and stories within that data that lead us to value or no value. I mean, I think it's open to say that there are things we'll find that we surface that go, whoa, actually, turns out we don't make an impact on that. But use that data, no data untapped, and leads to sort of this validated learning and the learning loops. And then I think that maybe the 2 new points on this slide is, one is accelerating the feedback loop. We had such a good discussion. I didn't push hard on that. Some days I'll actually say, so how long did it take you to measure that? Do you think you could have done it in half the time? Ask yourself that question as you're thinking about measures. Can I do it faster? Can I push faster? Improves that pace of learning quickly gets closer and closer to the data, to the unpacking, as we've been calling it. And then finally, once you have the data, once you have the insight, once you now have new information, how do you use that to drive change? That's sort of the emergent part of the strategy. How do you do that? How do you use that data to drive change? I'm going to pause with that thought in mind. We are true to the speak of deliberate versus emergent strategy. If you go to the agenda, our deliberate strategy was this session ends at 2. It's 2:45, but also true to us wanting to make this valuable for you guys. And it felt like there was good discussion going on, so we continued it. We're going to do a quick 10-minute break. There's some snacks. Let me pause. Would love a couple of reflections, if you have some, on the process part of it. What worked for you, what didn't work in your organizations?
So I will say, from our standpoint, we have 2 regions. And our West region was already doing some care management before joining IOCP. Our East region came on board with the second wave, and I first got involved with that Sustainability Academy kickoff event in Los Angeles in November 2014 there. And I think what was beneficial for me and our team in starting up at that point was a lot of the discussion of the Wave 1 group, what they'd done to engage their different groups, clinics, healthcare providers, in getting them to get buy-in into the program and talking about what worked and what didn't work. And I think it allowed us to skip forward a few steps and have some success in early buy-in. So that sharing process of people who had gone before and done the work was very beneficial, I think, for our group.
So that's neat. So it's the carrying best practices and then the discontinuous leap it allowed you to do. Sort of the translational value was, well, we don't have to start here and redo that. Was there a deliberate way that you guys inside of your organization started doing those things? So like, how did you look at, here's where we are, here's where they are, let's skip some steps?
There were, I think it was, now I'm trying to remember the health group. Is there a Dr. Zach Brown that was a...
Marcus Zachary?
Marcus Zachary,
yeah.
yes.
Mm-hmm. Brown and Tolan.
Brown,
you have some of the
yes,
you have some of the right words all in there.
That's what it was. My last name's Brown, so I'm really fixated on that. So, but I remember him specifically talking about that. Hey, we get a lot better buy-in as we're meeting with people individually. And we did something like where we got before physician groups and in private and individual and approached our first data mining where we identified our high-risk individuals. I actually called up the physicians and talked to them individually about, hey, you're going to get a list of 8 people, 10 people. Would you mind looking through this, and I'll follow up, and we'll find out who's good to contact, and then using their offices then to make those reach out contacts there. So I think it allowed us to that first wave of when we got people, we had a very high enrollment rate in the 90% range because of that. Right. And so I really appreciated the steps that had gone through beforehand of things that hadn't worked. So
that's really neat, and it's a great example of how specific our best practices need to be as well, and then how do you translate that into your organization in that level of specificity. And so as you spend today and tomorrow, I'd push each other to be real specific, I think, in the learning opportunity. And as you go forward, of course, as well, I'd push yourselves to be really specific on that, because it's easy to get up and sort of say, here are 5 best practices on engaging physicians, and I think that's what Dr. Zachary had started to talk about. But what does that really mean? Like, so you could say lunch and learn, but I think what he described that day, and I remember, Aaron, what you're talking about, was a very deliberate, sort of precise method to doing that, including, he said, in my emails, I sort of had a personal call out, sort of almost a begging moment of like, hey, I'm just a poor medical director stuck with having to do this. Can you help me? Can you help me? But that level of detail actually matters a lot. And it's a little bit of what we were trying to drive through in the action community, is get as detailed as you can in the work that you're doing, because then you'll know which component you iterate on. Other thoughts? Anyone else? Maybe one more sharing?
Thanks. I really appreciate your opening comment about beginning. And I think that's what we learned most from this project is we just started it, and it was overwhelming, the amount of patients that we were committed to, and we weren't sure how we were going to do it completely because we didn't have all the resources in place. And then in the beginning, we had 1 or 2 nurses that didn't work out the way we thought they were going to work out for the job that we had them for. And, you know, we were just talking yesterday about another grant program we're going to be starting, and it was the same kind of issue. Well, this is overwhelming, and how are we going to do it? We don't have everything in place. And I said, we just do it. You just start, and you just do it. And then every day, as things come up, you solve them. And it's amazing that you do solve them, and then you learn something, and it leads you maybe in another direction than what you would have made the decision. I find that there's, I feel like I'm an organized person, even though my desk is always a mess at work. But organization can be a curse, too. So of someone who has to be really organized and have everything spelled out completely before they can start a project can be a curse, because then you don't open yourself up to change that could really improve what you're doing. So I do appreciate that, and I think that's the biggest thing that I've learned from this project, because we're just so happy with the accomplishments we've made with this program, and not only in working with you, but the outcomes that we're seeing with our patients and the adoption that the organization has made for a senior program because of this. So that would be my biggest takeaway. Just start, just begin, and see what happens.
That's neat. A whole bunch of really great things. Thank you on that. So start before you're ready, almost, is what I hear, which is a really nice framing. And that it's constant change, destination unknown. Like I'm not sure where it's going to end up, but I know we'll get there if we're moving continuously in the right direction. It's sort of a bit of unpacking, if you will. So we're going to get there. We have to kind of unpack the big task into smaller pieces and get there. And then I think what you described sort of towards the end was that context that's laid out around deliberate and emergent strategy. I don't know if you guys remember that from November. We'll cover it again a little bit later. But this idea that we think we know how we want to go, and that's what you described, the person who has everything listed out. And that's great if you have everything listed out, as long as you're open to knowing that new information is going to come that's going to ask you to change. And so your deliberate strategy, if you sort of, with blinders on, go forward, you're likely not to be successful. You have to allow emerging strategy to come into your strategic planning, and that's really important. Thank you for sharing. And it is, what Erin and Jenna both shared was sort of around this process, this notion of you have to agree to a process of how we're going to do things. And you can apply that to other things then. So your new grant can kind of have this process, this learned process applied to it. And I hope that as we go through today and tomorrow, you get more sort of ideas around how you're going to hardwire that process in your organizations and hear from each other around that. So this is a lot of what we did with sort of these review routines, best practice sharing, and I think that was shared in both Erin and Janet's comments. And one of the most important things about innovating is actually reflecting. And so we asked you to do that a lot, and we'll continue to ask you to do that, hopefully as you move forward, is looking at what just happened, evaluating how you're doing while you're doing it, so it drives you forward. If you don't really know how you're doing while you're doing it, you really can't adapt. You can't sort of take in the information for emergent strategy. And so the whole process is around sort of process improvement with a little bit of a twist on it, I think, in ways that maybe your organizations hadn't done it before. And the focus really is on emergent strategy. So, and those of you who are in November probably remember this, but there's a diagram where you see our deliberate strategy coming in. I guess if you're looking at it this way, deliberate strategy coming in this way, that's what you're doing. That's the plan you have in place. Lots of things happen, and along the way you have discarded strategy because you realize parts of your strategy weren't going to work or weren't valuable to the direction you were going. And what you have is new information that comes in that helps you have emergent strategy. The hardest part about doing good action-oriented work is emergent strategy. It's actually a lot easier to do deliberate strategy, to sort of sit down and say, here's everything I know, I'm just going to make a plan. That's, in software, they talk about that as sort of a waterfall strategy development. So this idea that I'm just going to cascade all the way through, versus now how software is built with this agile development, which is this notion that we have a general sense of what we want to build, of what our customers need, if you will, and in your case, your patients may need, or your providers, or whoever you think of as your constituency that you're building towards. And I have a general sense of where I'm starting, but I absolutely know the hard part is assessing as I'm going to do the emergent strategy components of it. That makes sense. So that's sort of that emergent strategy. Do you guys have any examples of where you had something super surprising happen on what you were working on that led to a whole new emergent strategy? Janet, Chris, do you guys have thoughts on that? Because I know you mentioned surprising things that might happen or things you didn't expect.
One of the things that happened with us is, we're not set up as a home care agency. We do have nurses embedded in the office that are seeing patients, but we also had a social worker and a nurse that were going to the home to do that super visit per se, face-to-face, when a patient couldn't get into the office. And it was going really well, and then she had a car accident. So she wasn't hurt or anything, but she was very upset, and then this whole thing came up about how we really didn't have a process or a policy in place for a situation like this. There was a home care division that had something in place, but it had never been done for our division. So that was kind of, I think that was the most upsetting thing that happened, because I thought, how did we never even think of this? That we never even thought it out ahead of time, and then it happened, and it actually worked out okay. We're still actually refining the policy, but that was like something that was upsetting and that was surprising, and we had to stop the visits for a while because we weren't sure what we were going to do, and we were really making a lot of progress about getting those connections with patients who couldn't come in. So it was a little bit of like, oh no, now what are we going to do?
Yes, a deliberate strategy was we're going to do home visits for patients who can't come in. Well, then you got new information, which is, oops, bad things can happen when we go to patients' houses. Totally unintended accidents can occur, which led to emergent strategy. Well, we have to fix that part of the gap we have inside of our deliberate strategy. We had another group share with us that they had a deliberate strategy, a pretty good one actually, around enrolling patients, and then they were getting really low enrollment rates. They were, I think it was more of an IPA setting, so they were sort of outside of the doctor's offices and didn't have the benefit of the doctor's relationships. And so they said, well, deliberate strategy, let's really focus on the enrollment. Here's exactly how we're going to do it. Emerging information, we're getting not that great enrollment rate. We have to come up with sort of emergent strategy. And they said, well, let's look within that at where our enrollment rates are good, and it's people coming out of the hospital. So new emergent strategy, let's enroll people as they're coming out of the hospital to get sort of a bump up as we're going forward. So another example, Tiffany?
So when we started, when came here, we had heard about how most places were using RNs, and that they also, social workers were really helpful and that type of thing, and that MAs and the other type of allied professionals were used more just in supportive roles. And we started with an RN, and we also started with a couple MAs, and I think that we were surprised to see that our MAs were actually completely embraced the program. They were doing whatever, and they were functioning as full care coordinators and did really great. And so we kind of changed a little bit of what we thought. And we have an RN, we've got a social worker, but our MAs have been kind of the strength of that team, and they've really been really the driving force behind it and keeping things. And they've come up with ridiculously creative approaches to how to solve different problems and things like that. And so we have the luxury in Arizona of being able to use MAs in that capacity. They've even gone out and helped do home visits and things like that. And so we were pretty open when we first started our program. We were the same. We're like, let's just start it and we'll figure out what happens. And we went and did probably every other week meetings and really just moved along the path. Whatever seemed to work for somebody else, then everybody else would kind of glob onto that and say, yeah, this is now going to be my new process. And that's how we figured out where our process was. And then as we've been adding new team members, we've got a pretty good strategy of how to bring them out and how to get them successful, but knowing they're in different practices, that each practice is a little different. So one thing that we look for is flexibility in our care coordinators. So it's been very successful for us.
That's really interesting. And on that last part, what you look for on flexibility of care coordinators, just before we leave you entirely, I wanted to ask a follow-up. Did that change sort of how you hired as well? Did you start thinking differently and then hire differently?
Absolutely. I think we started looking for experience was the first piece, and then we use a tool called Predictive Index, which if you don't know what it is, it's kind of your work personality. And so we look for certain traits that are how helpful are, what's your tie to people, and how flexible and patient are you. And those traits seem to be those things that have been helpful. And then the other thing we look for is people that are more, I'm forgetting the word right now, but they take things into their own hands, and so that they're problem solvers. So we found that a lot of times getting RNs, especially from our hospital system, they were just very regimented in their thinking, and they didn't go outside. There was not a lot of creative thinking that went outside of that. And so for this role, for the care coordinator role, it was better to find people who had been in office practices and had those kind of attributes, rather than looking at pure experience, the hospital system, because that actually turned out to be a little bit of a detriment.
Yeah, that's neat, actually. I love that sort of broad context around deliberate strategy on your care team. It was going to be nurses, social workers, MAs supporting them, and the types of people you were hiring were based on experience set and maybe based in knowledge of complex care, et cetera. And then sort of information happened. You were out there, you were learning, and it changed pretty significantly the direction in a positive way. And I loved how you said, well, every 2 weeks or so we'd sort of pull up, and that's sort of that reflective process that needs to be part of agile development, if we're thinking of ourselves as agile development. And I think that example is one that we hear around the country a lot, which is that teams sort of build their staffing models based on what they think or wish would be the right staffing model, and then learn along the way that we just don't get it right. And it's a tough one, because staffing model is hard to reverse. So having agility in staffing model is actually a pretty great example of something that, as I think of building, if I was erecting a complex care model from scratch, I would start admittedly saying, I don't know what my staffing model is going to be. I think these are characteristics I need and capabilities I need. And then let me hire a few people who fit that, who I think could be role diverse at some point, and then figure it out going forward from that. Dr. Payton.
Okay, yeah.
Oh, sorry, I'm sorry.
And then something that we've really just discovered is as our nurses are embedded and they do a lot of face-to-face with our patients, as the patients would deteriorate and became kind of fell into that palliative care capacity and would expire, the nurses were becoming overwhelmed with that, the much-needed care, and then just that close relationship with the patients. So we've just, we've had to really work closer with the palliative care program to kind of offload that emotional capacity of the job. And so that's something that we've had to kind of continue to work on because of the nature of this particular model.
Yeah, and something that maybe you could have guessed would be important, but you didn't have sort of critical in terms of your sustainability, and it becomes sort of this emerging need. Dr. Payton.
I remember in the early months of the project, there were a lot of conversations about different models, the distributive versus the embedded. And I had a bias towards embedded, but it was not something we could achieve because of the number of staff and the number of locations that we had to deal with. And now I'm listening to this discussion and thinking about how, if we had gone the embedded route, I would have felt less flexibility and less ability to be nimble because of the way in which the practice environment establishes expectations and roles. Even if we gave them a template to start with, it tends to become fixed. And you don't, also because you're not going to staff with a whole team probably in a single setting, you don't have maybe the same flexibility of passing off one task to another person. So I'd be really interested over this 2 days if those who are predominantly embedded model would talk about what challenges they've faced with adaptation and even making conscious change to the model, given the whether they really feel like there are restraints and limitations imposed by the practice environment.
Yeah, it's an interesting observation that we do traditionally in healthcare have pretty constrained processes in practices or in hospitals, as Tiffany mentioned as well, that you sort of show up and you know what your work is going to be all day. I mean, my colleagues who are primary care docs will, when I ask them, well, what do you do every day? And they say, I just show up and do what my schedule says. I mean, that's sort of what I do. And what you guys have is the opportunity of flexibility, and then how do you put that or have that be part of a relatively rigid process? Because the practices and the hospital departments are not going home every day and saying, how can we be really agile? I mean, that's just not part of the conversation most of them are having. Really progressive ones are. But so that's a great question. I don't know if there are thoughts immediately on that. Jan?
So we have kind of a hybrid model. We have, let's see, 7, 11, about 30 people on our team. Some of them are nurses, some of them are social workers. The majority, however, what we call a community resource aide, an unlicensed person. Most of them have worked in a clinic, in a practice. They have great knowledge of the community resources and have actually built up quite a electronic workbook around all different kinds of resources that they tap into. Our embedding model is that every practice, based on their attribution, has one of that team embedded in their practice for a specific period of time. So it depends. If there's a really very active practice, somebody can be in there for the better part of a day every week. Somebody else will have somebody in for a half a day every week. Somebody else might have somebody there only every other week. We have a couple of single provider practices where they have somebody that goes in once a month. And they have different functions while they are there. So we kind of incorporate our population health with that. We take in the provider's list of frequent ED users, gaps in care, so they have one or more at-risk diseases, but they haven't been in there for almost a year. You'll have people with at-risk diseases that are clearly not well managed. And so we take that list in and we encourage them to get them into care coordination. Our teams are regional, so they have at least a weekly meeting face-to-face, so that when a CRA or the RN or whoever it is goes into their embedded practice, they have information about the patients from that practice and kind of where they are. Sometimes they hand carry the provider summary reports in to the office and actually have conversation with them about it. If there is a referral, they handle all of the paperwork, filling out the report, polling the demographics, all of that kind of stuff. We try to make them feel like we are an extension of the practice. We keep hearing things like, this just makes more work for me. How is this helping me? I don't get it. So we really do try to unburden them with a lot of the paperwork that we're asking for and that kind of stuff. So this is the same team, however, that will be doing the home visits. I agree with our Scottsdale friends that the MA, the CRA person, is able to do most of the work that needs to happen around these patients. It's the phone calls, it's the paperwork, it's the getting the DME or food or transportation. And clearly, you don't need an RN or a social worker to be doing that. In fact, that's one of our challenges because they have a hard time giving that up for some reason. I don't get it, but it is. They kind of don't feel like it's complete unless they've done it all. So our teams are 3 CRAs to 1 nurse and a half of a social worker. And we also have a pharmacist, about 1/3 of a pharmacist per each one of our teams. And then we have the post-acute teams that work with transitional care patients. So in our sense, it's not embedding or doing the home care. It's a mix, and it seems to be working fairly well. I can see the momentum gathering where physicians were uneasy about having us in the practice. They really didn't know what we were going to be doing. The biggest challenge for many practices is what to do with us in their space. They don't have space, they don't have a computer. A number of the practices have given us access to their computer so that we can load documents in, our summaries and that kind of stuff. That's really ideal. But many of them don't have a computer or a spot. I mean, even a space for us to stand. So I think that's one of the bigger challenges, especially with the smaller practices.
Yeah, thank you for sharing that. I think that's a helpful description of how you're doing it, and also highlights some of the opportunities and challenges that still exist in this embedded model. Other thoughts on that? One of the things that as you guys talk about the staffing models at large and sort of evolutions that you've had, I think almost at a national level, one of the deliberate emergent tensions that is there right now is our system is deliberately set up to sort of deliver medical care, something clinical, do something. And increasingly, we're finding that the do something that's captured in the billing side of things is different than the do something of what we really have to do if we wanted to sort of change the trajectory. And we're so hardwired in that deliberate strategy of the billing process, the revenue capture process, that's actually kind of hard at that point to have an emergent strategy. New information came in. It actually turns out the behavioral and social issues are bigger drivers, but we don't have a good mechanism to cover that, to pay for that, to be able to afford that inside of our health systems. And I think you're all figuring that out now. As a country, we're all figuring it out. And I can say, as folks who have been working in this space for a while, designing programs, we've had to be pretty emergent on that as well. We actually started with nurse-based AICU, ambulatory intensive care unit, really sick patients. They must have lots of clinical things going on. Within the first 6 months of that, we're like, wow, they do have lots of clinical things going on, but they have lots of other stuff going on too that we need to start figuring out and sort of have emergent strategy around. And I think some of the descriptions just in the last 10 minutes have been really interesting on that paradigm. And a little bit of a nice progressive thinking that we need to influence more broadly at a national level, where we do have some challenges and tension between the existing deliberate framework and the emerging information we're getting. Bill?
So at the Polyclinic, we have 12 different sites, and we do embed our enhanced care RNs into primary care. And it is based on attribution and where the physicians are located. So there are some nurses that are just about full-time based on, again, the volume embedded in and support 6 to 8 physicians versus our smaller clinics where we developed a routine schedule around where they float and cover. But in between, to address some of that need for flexibility, we actually float a social worker. So the task that our physicians and the physician teams seem to need assistance with are those psychosocial. So our social worker floats all of them and helps to compensate for some of that.
And how do they reach your social worker? What's sort of the process?
She does have a pager and a direct line, but we also embedded an electronic referral into our EHR.
Okay.
And you can route that at a priority.
Mm-hmm. So So you have sort of the care teams that are officially panel managing,
Correct.
and then the social worker who's a more immediate access option as
Correct.
they need it. Yeah.
For behavioral health aspects rather than medical casework?
She is, but since we're a multi-specialty clinic, one of the things that we had identified a couple years ago was embedding behavioral health into primary care. So we have a new program that's just a year old now, where the actual counseling, we have a mechanism to refer directly to them as well. And at the moment, their volume is so high that they're only handling internal referrals. So it's a priority for our system, our physicians. She can do counseling, but most of it's the psychosocial and other needs.
So the embedded took on a different approach for us. At first, we were thinking as embedded means in the clinic 5 days a week, and we actually started that way. And then the shift really happened that we couldn't be out in the home visits and trying to be in the clinic at the same time. And the intentionality came that rounding and ensuring that we were there when we said, even though it's 2 days a week, we commit to our fullest clinic, that we are rounding with the physicians. They know we're going to be there on Tuesdays and Thursdays. We are in and out of their office. We have a list of patients we're going to talk about. They, correspond back. But what we found the value is we call ourselves embedded, but we're not like come up and, which used to be, they could just call us and we'd come down. What they found the value is that nobody in the clinic, which is what you were talking about, the clinic is, they come in, they see those patients, nobody goes to the home and sees what's really going on out in the home. And the value changed from just being another person kind of in the clinic embedded, who are you, you're like a nurse. In fact, it took a little while for people to understand. A nurse comes and sees patients in the clinic, and then all of a sudden you're not here all the time, and are you just kind of almost like goofing off kind of thing, leaving your job. But what the value really came was nobody else goes out in the house and sees